So we have a tradition now, after hearing from each of you individually, we find it's really helpful to have a roundtable so we can discuss among ourselves and hear from each of you advice that you would have for us on the report that we will do. So the tradition is to ask each of you, and we'll go down the line starting, we'll start with Ruth, and that's okay?
I have to catch my breath. So
okay, we will start with Robert then. One piece, if there's one specific issue that we address, or one specific recommendation or finding that you would advise us to include in our report, what would that be? I know that's a question that requires you to set one priority, but it's proven to be very helpful to our deliberations. So let's start with Dr. Green.
Well, I'll come back perhaps with other comments. I'll keep this short. I think one point you could make is to sound a clear call for or against, or somehow better characterize the return of findings in research. When we started our ACMG recommendations, in part it was driven because of my experience with Susan Wolf's panel and think tank on incidental findings in research. And my thoughts were, you know what, we don't have a standard for clinical return of incidental findings in order to look to, the way we do in radiology. So I thought, well, really to make sense of this, we have to have a standard in clinical, and it evolved from there. I worry that the ethical drive to return incidental findings in research, however good some of the outcomes may be, obviously, turns the research enterprise into a proxy clinical enterprise. And I'm concerned about that. So I guess the one thing I would say is see if you can take a nuanced stand on return of incidental findings in research such that you don't burden the researcher with this clinical proxy.
Good, thank you. Dr. Chow.
I agree with that, and I also think that any kinds of recommendations about incidental findings should be informed by data about the potential risks from the inaccuracy of the findings. And I realize that that is in flux, but I think it's something that should be included in the calculus.
Correct.
Both for research and clinical, because I think this comment that Peter made about being clinical grade versus research grade, I think at this point for many new technologies, there's not much difference.
Thank you, Dr. London.
Yeah, I actually agree with the last point that Dr. Cho made about emphasizing, that for many of these, so there are going to be clear cases of things that jump out at you, and then the difficult cases are going to be ones where there's pretty substantial uncertainty. I think our practices here have to be informed, by how should we make those decisions under uncertainty in a way that is respectful to participants. And in that sense, I think I would caution you not to view incidental findings as a potential ancillary benefit of participating in research. I think that's a misguided way of thinking about them. And I would think of it more as, how is it that we ensure that when people participate in research that we take their interests seriously, where the other side of that too is that poor quality information can also cause harms to people.
Thank you, Dr. Bandatini.
Actually, from this discussion, it occurred to me that it seems like there's a natural division of detection versus follow-up as well. And so I think that the big area of at least uncertainty in neuroimaging is detection, is what's reasonable in terms of what are you going to do to detect it, what kind of expert and whatever. So that's, I think, needs to be grappled with. And that's where I kind of meant that there was a slippery slope potentially, is that you can always do a little bit more to try to detect.
Yeah.
And then where do you draw the line? In terms of follow-up, the open questions are, do you pay for the follow-up, or do you have a mechanism for paying for the follow-up? And at least there has to be a clear mechanism.
Thank you. Dr. Hildenberg?
I think I would just say I view my main role here as reminding you that despite being research subjects, we are humans. We are people. We have contexts. And not to forget to pay attention to that human side.
Thank you. Dr. Cowan?
Thank you for letting me catch my breath and look at my notes. There are two things that I found really interesting to pursue in this morning's conversation. One was the notion that we should stop thinking so much about benefiting individuals and start thinking about what benefits families. The other was the notion of referring and really considering research subjects as partners rather than as subjects. But I want to make one suggestion that combines my notion of the socio-technical system with some of the remarks that were made, particularly just recently, about research findings that get turned into proxy clinical findings. Surely we can find a way, a structural way, to include clinicians as clinicians, not as researchers, but clinicians as clinicians in research projects. And maybe even find a way, in the case of research that uses MRI, to have clinically adequate MRI imaging required, access to it required in the research proposal. I mean, NSF has found all kinds of ways to require potential PIs to do things that they didn't get trained to do, like figure out what the social significance of their research is. Why can't we require researchers to begin adding people to their teams or roles to their teams that research didn't previously involve?
So what I would like to do is open it up, and I know there are questions from this morning that we didn't get to, and I'm going to give Dan the right of first questioning because he was on the queue and got left off. So the last shall be first.
Thanks. Actually, follow up with Professor Cowan to give you a chance to talk to us a little bit more about something you emphasized in your presentation but didn't come up at all in the discussion, and that's the law of unintended consequences. And I think you're right, very right to point it out to us. I think you're also very right that the innovators are never the people who have the expertise to do so. But I was wondering if you could perhaps help us and say who could be helpful in predicting the possibility, anticipating possible consequences. Is it just always absolutely anything can go and there's no way to anticipate these things? Because it seems to me that quite often a lot of these allegedly unanticipated consequences seem very obvious, at least retrospectively. And I wonder whether a bioethics commission, for instance, isn't an important place to begin to really look very seriously at those kinds of questions. And I wonder if there are techniques or people, inclusiveness in terms of who we talk to that might help us in looking at unintended consequences, both for this or for other technologies that we take up.
It's very difficult to do. There have been many attempts to do it. There once was a Congressional Office of Technology Assessment, which contracted with sociologists, political scientists, specialists in whatever the field was that the technology was being assessed. And they turned out to be not very good at it. Social systems are so complicated that it's very difficult to make predictions about them, even when you know a lot about them. But I began my presentation by suggesting that historians have something to add. They can at least look at other past examples of unexpected outcomes and where they arose from or how they arose. But many social scientists have enough training in what we now call science and technology studies to do the same thing. Can we be predictive 100% of the time? Probably not. But we could try to make a stab at it.
Jim?
Dr. Cowan, also, your comment in the opening of this round, where you were talking about how it might be possible or even required to have physicians on standby, or possible even be required to, in the case of neuroimaging, to have clinical quality imaging. A principle seems to emerging, I'm not sure I'm comfortable with it, that if clinical benefit is possible, steps ought to be taken even in research to make certain that it's assured. Is that what you're suggesting?
It was an idea that popped into my head about 5 minutes ago, so
Oh.
I have not thought about all. Actually, that's not true. I've been talking with consumers, let's call them generally, about incidental findings for a number of years in the context of chairing the Community Advisory Board at a big health system on Long Island. And what comes up constantly from consumers of healthcare is the question of why can't a CLIA-approved lab be affiliated well enough to look at the research findings and report them to me through a legal lab? I mean, to ordinary people, it seems inconceivable that this can't be done.
Yeah, I guess I was looking more for comment, and I think Mildred had a comment, if it should be done.
Yeah, well, that I'm not sure. Actually, I am. I think it should be done.
Mildred, do you want to comment?
Yeah, sort of on that point, I think, well, I have a story of a incidental finding from a research laboratory at Stanford that came to us at the Center for Biomedical Ethics with a request for a research ethics consult. We've actually, about half of our consultations have been about incidental findings, so it's clearly something that's on the minds of researchers quite a bit. But in this particular case, I think it illustrates sort of what Christine and Anita had brought up earlier, which is this issue of follow-up and how far the obligations might go for researchers. So in this situation, there was a study that was being done where the researchers thought they had an incidental finding that needed to be reported because of it could be life-threatening immediately, having to do with high blood pressure. And they tried repeatedly to contact the research subject, repeatedly being 5 times by phone and by letter, and was able to get a response. And the person died, it turned out. That was partly why they didn't respond to some of the later letters. But so he had a good excuse. But of course, the researchers were distraught because it did fall into that category of we thought we had to do something, we tried to do something, we failed. What could we have done better? And I think the issue that this illustrates is that I don't think this person would have been turned away had they come to the hospital for care. There was something that could have been done. There was something that could have been done cheaply, so that wasn't an issue. But the person didn't have health insurance. The person didn't have a doctor, so it never occurred to them to even come to ask for help. And so I think that this issue of people wanting to get information, it sort of there's a number of people there who, as you said, maybe don't have friends or don't think they have friends, and so they won't even avail themselves of services.
Yeah.
May I have a follow-up? Your comment about where clinical benefit is possible, ought we to assure it, reminds me that in the 1980s, doing clinical trials at Emory, I got troubled by the notion that we were receiving laboratory studies and they showed things, and some of the subjects didn't want us to contact their physicians. So we felt caught in the middle. So I actually started on my own requiring that in order to be in our studies, you had to give us the name and address of your physician and permit us to contact them with any information that we might find. That actually took us out of the middle of this quandary. And so I wonder, I've suggested this to Susan Wolf on a lot of occasions, and everybody, all the ethicists hate it because it means that, you know, you got to have a doctor, you got to share information you might want to keep private and so forth. But on the other hand, if you did this in some way as a requirement for certain kinds of research, it takes you out of that uncomfortable position and flips the information to the clinician where it actually arguably belongs.
It's definitely worth our considering. I have Barbara and Raju. Sure, go ahead.
I just would like to say something about the previous. I think when we think about researchers' obligations, it's important to distinguish what are their obligations prior to disclosure. So when they see something that might be worrisome, what is responsible treatment of that, vetting it to get a more reliable read on it or whatever before disclosure. That's one area. Then the other area is, what do you do after disclosure, and how much of it is the responsibility of the researcher, and how much is it a responsibility of linkage to care? And the research system is part of a larger social division of labor. And I think two things that we have to, one thing that's part of the research system that needs to be reformed is making sure that people have insurance for research-related harms that they might incur. I don't think incidental findings are research-related harms, but if you don't have general health insurance, then research-related finding can have really, momentous consequences. And so we want people to participate in research, to contribute to generalizable knowledge, but we want to do that in a way that doesn't, overly burden them. So I think linkage to care is probably a sound compromise between derailing the researcher to then provide clinical care, which some researchers won't be able to do, and sort of dumping it on to the patient and saying, well, we hope that you find some way to take care of this.
Thank you. Barbara?
Yes, I wanted to go back to the public health issue. I think a lot of us are intrigued by that whole concept and hadn't really thought of it. And I have really two parts. One is, you said there were some states that do maybe 7 tests and some that maybe that does 50 tests. Is there something that determines who's deciding on what basis how many is the right number? Because it's going to be our struggle with the whole incidental findings. It's what's important enough, and we've talked about that a couple times. And whether you lose sleep about it doesn't seem to be enough of importance. It seems that either there's something that you could do about it, or there's something you should know about it ahead of time. So that's one half of it. And then I'm not sure if I heard you correctly on the other part, but were you implying that if you did the test on the newborn, that you would know something about the family, and then you could actually infer that the parents may have some genes that you should be looking at? Are those things actually happening? Are there really research databases now of these huge numbers of babies that have been tested that may have some information that may be applicable to the families in general? And should we be actually thinking about recommendations relative to all of this in our report?
So about the first question, the average number of tests done in the states now for newborn screening is about 50. So it's not a few, it's many more than that. How the decision gets made, it's state by state. Now, there's been a lot of attempts to try to harmonize that, because does that make sense to have every state be different and make it dependent on what state you get born in to determine where you get what you get tested for? I think people agree that doesn't seem like it makes a lot of sense, but there's not really been any success at trying to harmonize all of the states. I know in California they're interested in starting to think about using whole genome sequencing or some kind of scaled up sequencing for both newborn screening and for prenatal testing in the state health department programs. Why and to what extent, I'm not really sure, but I'm going to find out in the next month or two, because I'm going to go meet with some of the folks in both of these, in the California Department of Public Health. And your second question was about?
Well, it's about whether they would use the information on the families, and I guess it also, would you then extrapolate that the parents might be getting Alzheimer's because you could test it in the child? Or,
Yes, yes.
and
when you
will
get,
they be following those children for 80 years to find out if they got Alzheimer's, if they decided they knew it when they were born, and those kinds of things? I mean, are people using this information for something, and should they be if they aren't?
Well, so if you do a genetic test, it depends on what kind of genetic finding you're looking at, but you could have the potential to find out genetic predispositions of the parents. And in fact, in some of the newborn or the prenatal tests and in the newborn screening tests, they do ask for parental samples in order to interpret the sample that is done of the proband. So, yeah, you will find out information. Now, the significance of it varies depending on what particular analysis you're doing and of what. But yes, that is one of the issues that I think needs to be considered specifically for the genetic findings.
Raju?
I have a question for Ruth Cohen. So, in your comments this morning, you talked about, trisomy 21 and the fact that, it was initially discovered for the purpose of trying to find a cure, and that eventually it turned out to be for a different use. And as you know, today, that test is used extensively for prevention. And I wanted to ask you whether you have a value judgment on the utilization of that test for prevention, and whatever that value judgment is, and why do you feel one way or the other about that?
Yes, I have a value judgment, and it's what I referred to at the beginning of my talk. I was puzzled by my own participation in this system on ethical grounds when I first had amniocentesis. And the conclusion of my research, which took a long time, not the research, but thinking through the ethical issues that I wanted the research to clarify for me, I came to the conclusion that it was a good thing. In fact, my book on the subject is called Heredity and Hope, The Case for Genetic Screening. And that it was a good thing because it respected the autonomy of a woman to make decisions about who she was going to spend her life caring for as a mother.
I have a question from a member of the audience, Les Biesiker? Les? This is a rather, regarding the question of whether incidental findings should be sought or only returned if stumbled upon. The latter approach, that is, only returned if stumbled upon, seems to be arbitrary and capricious. Is the latter approach ethically defensible? In other words, if you could go, this question opens either way, which is if you feel that it should be returned if stumbled upon, why not seek it? Or if you don't require seeking it, why return it if stumbled upon? That's basically, there are two horns here that you could seize either one.
Well, I think that at least in the context of neuroimaging, it's very practical. If you sought every single possible thing that could be wrong with somebody, you would be scanning for a day, at least, to try to see everything. So I think it's practical that that's not possible. So on the other hand, if you just do, most researchers, a lot of researchers would argue that they're doing research and not at all. They're not at all responsible for clinical. To even do anything that would help them screen the obvious things. I think that the answer is somewhere in between. It's sort of a little bit of just practical, what can be done, and there's a point at which you can probably collect a little bit higher resolution image during the scan and then look at it and say, oh, is this reasonable or not? And then if you see something unreasonable, bump it up to a physician. I think that's not really stumbled upon, but because you are doing something reasonable, you're not completely having blinders on.
Yeah.
So,
Nelson, I have you on the list. And you're up.
You're always very sensitive to that. So I wanted to delve a little bit more into the issue of potentially using linkage of care as sort of the way to get around the conundrum of not taking a research enterprise and turning it into a clinical enterprise. So I'll give you one anecdote from our own experience in my program in Nigeria, and then ask a question that isn't so theoretical. It's happened historically in my institute between the malaria and the HIV programs. So we worked, we do work in Nigeria. We do a number of scientific studies there, but we're also heavily engaged in the American Bilateral Program for HIV/AIDS assistance called PEPFAR. And as a consequence of that latter work, we went to an area very close to the capital city, only about 10 kilometers outside, that for reasons that were unclear, it just had sort of escaped the net of doing incidence studies or prevalence studies, and so no one really knew what the rate of HIV was going to be in that community. So we were looking for relatively high incidence populations that might prepare the way for vaccine studies there one day. And so we did an initial prevalence study, and we're stunned to see that the prevalence was in the 15 to 20% range across this population. And that immediately triggered, since our research team also sits on the PEPFAR working group in the embassy, it immediately triggered a public health response by the program in that country to make sure that there would be linkage to care. So from an ethical standpoint, we wanted to ask that question anyhow. So for us, it wasn't an incidental finding. We were seeking that answer, but it provided a very quick resolution. Now, so that's sort of the background. The more difficult conundrum that's come up from time to time in areas of the world that we work, where there is a very high prevalence of malaria infection, but also a finite prevalence of HIV infection. What's the ethical basis for a malaria researcher to say, well, maybe the incidence of HIV in this population is going to be relatively low, the prevalence will be relatively low. If I'm going to do a pharmacodynamic study looking at a new malarial drug, I'm going to choose not to screen for HIV infection in this population. It's not the purpose of my research. But understanding that this might be the best way for the public health community in that particular country to identify an actionable result. This isn't as straightforward as it seems. I mean, you identify someone with HIV infection in this part of the world, especially a woman. You develop a significant set of criteria that aren't always so positive, like stigma and social harms that can accrue to that. It also is a barrier to the malaria researcher to do her or his work. So, is it reasonable for researchers to, in fact, choose not to ask certain questions because they don't want to deal with the incidental findings that will come up with it, even though there is a public health benefit? I mean, how do you choose that middle ground?
I'm sure there are plenty of opinions on this, but briefly, I think it is reasonable for a researcher to choose this. I think the researcher's primary mission is to generalizable knowledge, and unless that is explicitly part of some hybrid mission, which it could be, I don't think that the researcher of necessity is requested, required, empowered, or funded to take on public health issues. If I also may just reach back to Barbara's question, because I differed from my colleague here, your question, do child results impact parental risk? I would say unambiguously yes. If you find that a child has a adult cancer predisposition syndrome, our recommendations suggest you want to give that information back to the family's physician because one of those parents has it. And far more frightening than that child having to be exposed to that information is losing their parent.
Dan.
Thanks. I was going to take us back to our definition of incidental again, the earlier discussion, because it seems to me that the way we framed it is that it's looking for finding information that's not the intended aim, right? But in fact, that works for an old paradigm in which, I would test for creatinine and find the calcium was elevated, or I'd do a scan of the liver and find there was a nodule in the kidney, right? That seems incidental. But the new paradigm seems to be, let's do a bunch of tests and see what we find. And that's what whole genome sequencing is in some ways, that the aim is sort of, can we find anything? And we know that even in scanning, you can do this. Again, nefariously, there are people who do screening tests of whole body imaging. So can we consider anything that comes up in those sorts of tests to actually be incidental, if that's the definition? And then, at least from a clinical point of view, or an ethical point of view, even from the viewpoint of screening, do you think that kind of testing is actually defensible?
Any takers?
How about context by context, clinical versus research, right? I mean, my point there is, if you take it out of the genome and say, if I'm going to study,
Start with the clinical, I think.
and then go. We'll have more clinical conversation this afternoon, actually.
I don't have an answer to your question, but I want to add another context, which I think is crucial, which is the commercial direct-to-consumer.
So let me take a question from our audience before I ask other commission members, okay?
You stumped the panel.
Philip Kalina. Philip, where are you? Thank you for this question. It has been suggested that participants in clinical studies be required to give contact information for their physician. Excluding participants because they do not have physicians or will not share their contact information has the potential to introduce new biases in the resulting sample. Good observation. Anyone? I see a lot of nods of agreement here.
Agreed, but volunteer populations for research clinical trials never were and never will be representative, so it doesn't matter.
I know that, John, you wanted to say something earlier. I didn't notice. Do you want to come back on it?
I just was going to say, in response to Dr. Michael's comment, that I think there are differences when you're working in a low resource setting, and and you know that there are going to be significant unmet health needs in the populations in which you're working. And you want to make sure that when you conduct research there, that it's expanding the capacity of health systems in those countries to meet local needs. So it may be the case that when you do testing in that population, that you can link to care in that population that both has a public health benefit for the country. Now, whether you could go there then and do a test on A, right, without screening for something else, I think there are often such vast unmet health needs that the question is, what is a reasonable contribution that we can make with the resources that we have available and in cooperation with the host community? And I'm not sure that that's really incidental finding, because a priori that you're going to have huge unmet health burdens. But I would say there that I don't think that the researcher can just say, I know I'm going into a high burden population, but I'm just here to gather data. Right? I think that's a kind of exceptionalism that would say my role-related obligations free me from, doing something meaningful in this population to help the public health system. I don't think that that's justified.
Anita, that's because it was Nita, and I wrote down Anita. Excuse me. I've done it before, and I
think that's maybe one of the first times that you've
I think I once did it before, but here we go. My record is not perfect here, but I will strive harder. Nita.
Thank you. So I'm struggling a little bit with some different perspectives that I'm hoping you can weigh in on. I've heard a few different people say with direct-to-consumer genetic testing, it's different because it's a contract-based relationship, and the contract doesn't require, or shouldn't necessarily require, the return of incidental findings, but that researchers should have a duty beyond the duty to just investigate what it is that they've set out to investigate and to look for or report incidental findings. And I'm trying to understand why. So is it not possible to define the relationship between researcher and subject and physician and patient in a way that a consumer company could define the relationship between the company and the consumer. So what is it that's unique about those relationships that say you can't define it and say the only thing I'm researching is X? I will not be running a panel on anything other than X, but if you would like me to, we could provide that service to you, but otherwise we will not be searching for it. So what is it that makes us say in these other contexts, you can't do that? You can't have the contract-based relationship that's limited.
I mean, I guess this does sort of get back to the question about if you stumble, what's the difference between stumbling upon something and actively looking for it? And I would say that the research, I mean, I don't know how to speak precisely about the direct-to-consumer side of this, all right? But it seems like reasonable to think that there's a continuum with the strong fiduciary duty on the one hand and then an arm's-length contractual relationship on the other, where you may be governed by, does your product meet safety standards, does it do what it says, and then caveat emptor or something like that. And in the middle, I think, is the researcher-subject relationship, where you're saying, look, I have an important question. I want to answer it, and to do that, I need your participation. And if participation means we're going to draw blood, and or we're going to put you in this machine, or we're going to do other things. So it's a limited relationship, right? Your relationship with your clinician is we're going to address my health needs, but in a reasoned, data governed way. But here we're saying you're going to participate with me to answer this specific question. And then if along the line something unintended comes up, then there are questions about what is your duty to assist that person? What does it mean to take their interests seriously? And you have a relationship with that person where that person's helping you to do something. They're contributing the data that you need in order to answer your question. I don't know if the direct-to-consumer side has that sort of relationship, but I guess that'd be a question for the panel later on.
But that's, so your view is what's different about the relationship is that you actually have something that you view as a special relationship because the person has agreed to help further your interest. It seems to me like you could say that about a consumer as well, that they're furthering the interest of the company, but maybe, there's something more there from your perspective. It's the public good that they're
Can I add a
getting.
comment to this discussion? Is there time?
There is?
Okay. The boundaries between researcher, clinician, and commercial entrepreneur are fading. For example, there are commercial enterprises that are doing research. There are clinicians who are doing research on their patients, with the patient's consent, but nonetheless, it's happening in the doctor's office, not in a research. So it may be that we need to rethink those distinctions because in reality, in social reality, they're not so distinct anymore.
I wonder, so I began commenting on Dr. Helgenberg's take it the basic, respect that any human being, no matter what relationship you're in with them, you owe to somebody else because it's just so obvious. But now let me make a comment on the other side, which is based on Nita's, I think, very helpful question. So we have public health people, we have direct-to-consumer people, we have researchers, we have clinicians. It's not as if these come with a platonic ideal attached to them of exactly what their obligations are and are not. As Ruth points out, these evolve over time, and they evolve in part due to policies that people make, due to cultural understandings they have. So here's my question, and it's not meant to skirt our need to actually draw some lines, but is there something to be said for having more certainty rather than less certainty here, even if there aren't platonic ideal lines to be drawn? And are we in an area now where there's so much uncertainty about whose obligations are that it would be helpful if we could do nothing else, to make sure that people know what to expect.
Well, that's a softball pitch because no,
I mean,
but
it's-
in a good way to the ACMG recommendations, because that is exactly the thinking that led us to say, look, we are ignorant of a lot of the evidence that needs to be, but there is so much uncertainty and confusion. We're going to plant a flag, and I agree with Ruth that the boundaries are fading between researcher subject, physician patient, and company customer. But I do think, apropos your question, there is still a primary duty in each domain that is different. The primary duty of the researcher is to discover new knowledge. The primary duty of the company is, I think, to survive for its shareholders, and the primary duty of the physician is to take care of their patients. That does not mean that each domain does not genuinely and authentically share other duties as well or priorities, but those can be negotiated by sort of contracts. So the DTC company has a goods and service, and then also has a consent form that enrolls people in research. The researcher subject has a consent language, and it can clearly say, you will not get anything back. And if that's clearly communicated, then the subject is clearly informed.
So I agree with Henry Richardson, and I think just as a moral matter, contract is nice. It's a way that we can try to define what we owe to each other, transfer rights and obligations and things like that. But I'm afraid that I'm one of the people who thinks that there are limits to the degree to which we can hive ourselves off from our fellow people, and that we could create contracts that say, I can interact with you to do this project, and then I can be completely indifferent to your autonomy or your welfare. So it may be an ambition that private corporations or researchers would like to be able to, be indifferent towards people outside of the narrow realm in which they're interacting. I just think from the moral perspective, you can't be done. Claims of assistance or aid they escape the bounds of contract. And so the other thing I would say there is, yes, it may be true. Clinicians are performing research in their clinics and corporations are performing research. Okay, insofar as you're doing those things, to me what matters less is the category, the name, the role. The question is, are you entering a relationship with a person where you're saying, join me in this enterprise where we can do X, Y, and Z, and then when you do that, you incur some added responsibility to that person, that if you find something out about them that's of momentous import for their interests, that you may have a duty to disclose it. And I say may with all the caveats that we've talked about.
Say momentous import as well, which is a qualifier. We are actually out of time, but I want to, we'll have one last question by Raju and one last response, not by everybody, but by a few of you, if you feel so moved.
It's not so much a question, but a comment. And I wanted to follow up with Dan Solmesi's comment, actually, which is a fundamental maybe to our discussion. And that is that, the way that the technology is proceeding is that it may be cheaper to be able to do whole genome sequencing than doing one test or two tests at a time. And when all of those results are obtained, then, those results, if it is a clinical test, that would become part of the medical record, and the medical records are owned by the patient. So it is not possible to actually try to withhold any information, and there are no incidental findings, as Dan is trying to possibly argue. I don't know whether that's correct or not, but I think that there is a very important case to be made here, that in those circumstances, there may be no incidental findings. I would love to hear, the panel's views about that.
Well, Robert, you talked about testing for 24. That's certainly not incidental once you tell everyone.
Well, I think Raju is right, and if you look into a little bit farther future, in the immediate future, it still takes work to interpret the variants, and you've got to choose which ones to interpret. So I think that But I totally agree that's where we're heading.
I think it is a really astute observation that we are heading in the direction where less and less becomes incidental. We're not there yet. And that's, if we were there, it would be easier terrain to navigate. I am going to conclude this session by saying what I believe is true, which is nothing that you have offered us today is an incidental finding for us. It is all something that we will take directly and use as best we can for making as good a report as we are capable of doing. And I want to thank you all for extremely helpful comments. Thank you.